Good evening once again. Uh, Great welcome to every one of you who has joined. I'm sure you all recall that our team, that is Team FSIBC, has been organizing monthly webinars since July 2020. 2020. That's been almost 5 years. And after covering all aspects of breast cancer management in 37 webinars since 2020, we have started a new series this year that is called as Deep Dive into Breast Cancer. So today it's the fifth webinar of this series, and today's session is dedicated once again to the understanding of breast pathology. In today's session, we are going to cover the uncommon areas of breast cancer, that is DCIS, then the B3 lesions, the stromal tumors, and the low risk breast malignancies. And we have a great team of faculty, which includes Dr. Tanuja ma'am, Dr. Kavita Jain, Dr. Ruchika, and Dr. Jyotsna Yashodharan. So I'm sure it's going to be a great, engaging, as well as an informative session, which is going to strengthen our collective approach to the breast cancer management. So to begin the proceedings of the webinar, I will hand over to Dr. Prekshi.
Thank you, ma'am.
Prekshi.
Good evening, everyone. My humble request to all the speakers to please stick to the scheduled time, and a request to all the delegates to put their questions in the QA box, which we will be discussing after the end of all the sessions. So we'll start with the first webinar, which is regarding DCIS. So DCIS, which is actually a precursor of invasive cancer, it is very heterogeneous disease and challenging too. To discuss all these aspects, we have with us Dr. Kavita Jain, who is Senior Consultant Oncopathology at Apollo Athena Cancer Center, Delhi. Over to you, Dr. Kavita.
Thank you, Dr. Prekshi, and thank you all the organizers for inviting me to this interactive session. Really happy to connect with all of you. I'll just share my screen. So is it visible, ma'am?
Yes.
Yes. But I think slide share mode पे नहीं है अभी.
हाँ, I'll do that. Yeah. So I'll just go ahead.
Yes. Yeah.
So before diving into the complexities of DCIS, I would just ask all the panelists and the delegates that if you have any query regarding, management of DCIS, that is what problems do we face for diagnosing as well as in the management, kindly just drop into the chat box so that we have more interactive section at the end, session at the end of the webinar. So to start with, terminal duct, this is the normal, I'll just show the normal breast parenchyma has terminal duct lobular units, which comprises of ducts and lobules lined by intact biliate epithelium, where the luminal epithelium secretes, is responsible for secretions, and the myoepithelium provides the structural support as well as contractile function. This rests upon the basement membrane and is surrounded by a delicate stroma. So all in all, this is a microarchitecture of breast which maintains the shape of the breast, and any pathology in any of the three will disrupt the normal microarchitecture. DCIS per se is a malignant epithelial proliferation in the ductal lobular system, whereby the myoepithelium and the basement membrane stays intact. So the true incidence is not known. However, with the advent of screening programs and the screening awareness, the incidence of DCIS has raised to 20 to 30% of all the breast cancers in areas where active mammographic screening is taking place as well. However, in areas like ours in India, I should say we fall still under less than 5% population where screening awareness is lacking. So I would quote an article which was published in The Hindu in 2019, where they say that the precise statistics on the incidence of DCIS in India is not known yet. And one of the pioneering institutes on breast diseases, which Center for Breast Diseases in Hyderabad, had done a study on this. So what's the clinical presentation of DCIS? Most commonly, they are detected on screening as calcifications. Less than 5% are detected as palpable masses or nipple discharge, and less than 1% are detected as Paget's disease of the nipples. So what's challenging about DCIS is, as Dr. Prekshi said in the initially while the introduction, that they are heterogeneous group of lesions with varied histologic, immunohistochemical, radiologic, and clinical characteristics. And this heterogeneity is reflected in the natural progression, where some DCIS cases, they remain indolent, while others progress to invasive duct carcinoma. Few long-term studies have seen that up to 70% of the DCIS cases, they never progress to invasive duct carcinoma, although there is an ongoing debate on risk stratification of risk of overtreatment versus undertreatment in these cases of DCIS. So if we come to the models, there is a theoretical linear progression which we all think from atypical from hyperplasia to atypia and to DCIS, followed by invasion. However, the epidemiologic studies have suggested that DCIS is a non-obligatory precursor of invasive duct carcinoma, meaning that there are alternate pathways. Not just DCIS, but there are alternate pathways which predominate, and they can give rise to IDC, not DCIS directly. So one of the models suggests is independent clonal lineages, where we say that in a duct, two different lineages, independent clones might arise in different ducts. Few may remain as DCIS and few may give rise to invasion. The other model is the evolutionary bottleneck model, where in the same duct, multiple clones may arise and few clones may give rise to invasion, whereas other may remain, DCIS remains predominant and invasion is because of the other clonal lineage. So what are the precursor lesions for DCIS? Predominantly, there are flat epithelial atypia and atypical duct hyperplasia. And again, the same rule applies that they are non-obligate precursors of low to intermediate grade DCIS. These lesions have karyotypic abnormalities in the form of losses at 16q and 1q that are also found in DCIS, as well as other members of the low-grade breast neoplasia pathway. A precursor lesion for high-grade DCIS has not yet been identified. The risk factors are similar to invasive carcinoma. That is, the family history, atypical hyperplasia, estrogen exposure. They're all in all, they're absolutely similar to invasive carcinoma. And even the hereditary genes like BRCA, they have been shown in around 13% of women with DCIS before 50 years of age. The BRCA1, again, as we see in invasive carcinomas, they are often associated with high-grade DCIS, which are triple negative. And BRCA2 is associated with ER-positive DCIS most commonly. So coming on to the morphology broadly, morphology of DCIS is a three-tiered system where we look the DCIS on the basis of architecture, nuclear grade, and necrosis. So based on the architectural road pattern, although there is no clinical relevance to any of the architecture except for comedo pattern, but of course, they would help us by knowing that the precursor lesions, as well as risk stratifying these patients, that they are there. Then, for example, we have micropapillary DCIS, where we see the proliferated cells as multiple papillary fronts into the lumen without prominent fibrovascular cause. And in the absence of micropapillae, we call them clinging or flat DCIS. So now we are no more using this term clinging carcinoma, but in 1979, Professor Azzopardi introduced this term, and he emphasized that these are those lesions which can be, the alteration is cytological rather than anatomical, as if we won't see the proliferation of the epithelium, but we should closely watch these lesions for the cytologic atypia. So this type of DCIS occurs in a background of columnar cell hyperplasia. So nowadays, I think, can you hear me, ma'am? It's showing internet connection is unstable.
You are audible.
We
You
can
are
hear
audible.
you, but
So
there was a
columnar cell hyperplasia. The columnar cell hyperplasia is one of those lesions which I really believe should be reported as and when seen, even on small biopsies, because these cases should be stringently followed in a span of around 6 months to 1 year, as the low-grade DCIS is followed, because they can be a precursor to DCIS as well as invasive carcinoma. They have a high relative risk. Cribriform DCIS they give a fenestrated epithelial proliferation look. As we can see, they are punched out. There's a punched out appearance of the lumina, and we have monotonous cell population. So the secondary microlumens which are formed by the epithelial proliferation are rigid, punched out, or cookie cutter appearance, as we say. So differential diagnosis of cribriform is solid papillary carcinoma, is another form of DCIS. The differentiating point of morphology is these lumen where the epithelial cells are palisading around it, giving it a pseudo-rosetoid appearance. And of course, the presence of synaptophysin or chromogranin, the neuroendocrine markers in solid papillary carcinoma. The second benign differential is collagenous spirulosis, which so closely mimics the cribriform DCIS. For this, the pathologist should be very careful, as these are polymorphic cells which are proliferating. They may include both the epithelial as well as predominantly myoepithelial cells around the lumina. And the differentiation can be done on the basis of IHC, like CK56 and P63, wherein CK56 will be lost in the DCIS proliferated cells, and it will be intact in collagenous spirulosis. Now, comedo is the most important DCIS to be reported, not to be missed. These are solid growth of pleomorphic cells with high-grade nuclei, central necrosis, and calcific deposits. So, true comedo necrosis should be definitely identified from, distinguished from the secretions as well as the histiocytes, which can look like necrosis on LOPAR, if not experienced. They comprise of Ghost cells and cherorectate debris. And of course, I've taken an example. So this is the central necrosis, which we see. And this is the periductal fibrosis, which often confuses us with the foci of microinvasion. So this was one of our cases where there was abundant periductal fibrosis, marked periductal fibrosis, and we had to put the myoepithelial marker in many sections to rule out any microinvasion or a invasive focus in this patient. We had received mastectomy of this case. The solid DCIS is formed by neoplastic cells that fill most of the ductal lumen, and microlumens and papillary structures are mostly absent. It most often has to be differentiated from lobular carcinoma in situ, which as of now is not staged and not treated. So this can be done on the basis of E-cadherin. In lobular carcinoma in situ, we see loss of E-cadherin, whereas it remains intact in ductal carcinoma in situ. So this is about papillary DCIS, and a word on Paget's disease of nipple. So this is extension of DCIS from underlying breast tissue along lactiferous ducts to the epidermis, presenting as crusting. The pleomorphic cells are positive for HER2, and the differential diagnosis includes the pagetoid dyskeratosis and the Toker cells, as well as melanoma in situ, and both will be negative for HER2/neu. So the second, after the architecture, we have to comment on necrosis, as I've already emphasized. So the comedo necrosis can be of two types: either central, which is more grave, and it has a high risk of recurrence. So the central is expansile necrosis, we say. And we have the focal or punctate necrosis. We should always mention this while we are reporting. The punctate necrosis or focal necrosis is a single cell necrosis which is comprising of less than 10% of the entire lumen. If this is 100%, this is less than 10% to qualify as focal. And of course, depending on the, I won't speak much on this, depending on the grades, we have low grade where the cells appear monotonous and they're just 1 or 1.5 to get an estimate of how to report on low grade or high grade. The low grade cells are just one time of RBCs or the epithelial cells, and the high grade cells, high grade lesions show cells with more than 2.5 size of the normal ductal epithelial cell. And of course, they have other nuclear features as well. So how do we approach to a diagnosis of DCIS? And I think we should, in this section, I'm emphasizing on the imaging part. So we have a wonderful team of radiologists at our center, giving us a variety of challenges and cases every day. So on mammography, for example, these two cases, they came as just asymptomatic for screening mammograms, and they found that the predominant finding in a mammogram is the calcification, which can be fine pleomorphic, or it can be coarse, or it can be linear branching. So this patient had these coarse as well as fine pleomorphic calcifications. They even gave me this tomo picture where the calcifications are more easily visible, the fine pleomorphic calcifications. Similarly, in the second patient, we had a grouped calcification of coarse and fine pleomorphic calcifications. And these all patients, after we see the suspicious calcifications, the next step would be to go for supplemental imaging that would include either ultrasound or MRI. So ultrasound is not a great modality to look for DCIS. It's around 40 to 50% sensitive. However, in this case, for example, this patient was outside. She was reported as mastitis on the imaging, and she was labeled as benign. But when the probe was there, the probe was kept, an irregular hypoechoic lesion was found. When seen on elastography, it was red in color. That is, it was hard. Her MRI showed that skin thickening was there, but there was a non-mass enhancement. So a biopsy was performed, and this patient turned out to be a predominant DCIS with foci of invasion. Her FNAC on axilla was also positive for metastatic carcinoma. So this is the second case wherein the patient had a palpable mass, and the MRI was done, the mammo was not available, and we can see the mass-like effect in the left breast. Again, in this case, since the FNA was negative for the metastatic carcinoma, a VAB was obtained so that we can see a larger volume of tissue and look for any microinvasion. This was the third case. Again, this is a very good mass lesion with the patient presented with this mass lesion. But how the mammogram helped us was because of the extensive calcifications antero-inferiorly. And this patient had extensive DCIS in the mastectomy specimen spreading from one margin to the other, whereby I believe that my mammogram was underestimating the extent of DCIS in this case. So the third step would be to obtain the course or the biopsy from the suspected or calcifications or the targeted calcifications. So at our place, they remove, this is the VAB of one of the patients, and it was taken in a Petri dish, and it was cross-checked on mammogram whether the calcifications were retrieved or not. And then it was subjected for pathological study. So whenever we receive a biopsy, we have to confirm the presence of DCIS and other characteristics, and we have to completely rule out the possibility of invasive carcinoma, as the management clearly depends on the histopathology report. So coming on to the pathologist's perspective. So how do we approach a case on needle core biopsy? First, we ensure that we have enough cores, and the targeted calcifications, as I've already mentioned, are identified by the radiologist before they send us to the laboratory. The sample should be processed within 6 to 72 hours of fixation. We report them as per CAP protocol, and we have to definitely rule out the mimics on morphology and IHC. So these are few mimics to be excluded before we label the case as ductal carcinoma in situ. That is, for low-grade DCIS, the usual duct hyperplasia, for which we often ask the clinicians to get an IHC billing done to look for the nature of proliferated cells. So we put a cocktail of P63, that is the myoepithelial marker, and a CK56 to look for the proliferated epithelial cells. If they show the intact expression, that means it is in favor of a usual duct hyperplasia. Then we have atypical duct hyperplasia. We don't need any IHC for it if we are sure on the atypia. How do we define it? How do we differentiate it from low-grade DCIS? Atypical duct hyperplasia would be less than 2 millimeter of duct. When it is more than 2 millimeter, we label it as DCIS. And it will show, or if it is involving a larger duct, it will just show the partial involvement of the duct. Then lobular carcinoma in situ, I had shown E-cadherin loss in LCIS, collagenous spherulosis as mentioned above. Then the microinvasive carcinoma, which is defined as a stromal invasion less than 1 millimeter. It is associated with high-grade and extensive DCIS, and artifactual displacement can mimic a microinvasive carcinoma, where the myoepithelial marker definitely helps us by showing loss of expression along the invading nests. Again, one uncommon mimic is the lymphovascular invasion, because again, they can present as closed spaces with artifactual retractions. So here we can apply the vascular marker like CD31 or a myoepithelial marker to differentiate from LVIs. So on needle core biopsies, we report the histologic type, the architectural patterns, the nuclear grade, and necrosis, whether focal or central expansile, and microcalcifications present or not. So if we comment on microcalcifications, it would definitely give a relief to the radiologist that they have targeted the correct areas. So this is an important part for management recommendations. I believe when a pathologist is reporting on DCIS, they can put a comment depending on the findings they have seen. For example, if it's a confirmed DCIS of any grade, we can recommend for surgical excision to assess the full extent of disease and to exclude any associated carcinoma. If it is a high-grade DCIS with comedonecrosis, again the same comment. Now, if the DCIS is present but calcifications were not retrieved, we can put it as a discordance between pathology and radiology, and we can persist for, if it persists, we can ask for a repeat sampling or a stereotactic biopsy may be done to look for the targeted calcifications. Again, if there is a discordance that the histologic findings do not fully account for the imaging abnormality, additional tissue sampling can be considered. If no DCIS was found, but there was a high suspicion, again, a repeat biopsy, a core or a VAB is recommended. DCIS in papillary lesion, surgical excision is recommended. Suspicion of microinvasion, excision is recommended for definitive assessment with additional IHC, and ER status comment should be given with every DCIS so that it helps planning adjuvant endocrine therapy after excision. So approach on excision specimen. For specimens with a known diagnosis of DCIS, it is recommended that the entire specimen be examined and using a serial sequential sampling. This is my favorite way of sampling the DCIS, wherein if this is the mastectomy specimen, fixed mastectomy specimen, I divide them into flaps the next day after they are fixed, and I draw a diagram by blocking out. I just map the entire breast parenchyma and I block out each area, and this way I feel content that I'm looking into every area of the breast, and I can confidently, I am able to give the extent of DCIS, the size of DCIS, and the margins. We had a case where the patient had extensive DCIS, And grossly the margins were around 1 centimeter from the one of the margins. But when I took the mapped breast parenchyma and I took all the sections serially, I found that it was less than 2 millimeter. That is, it was positive for DCIS in a mastectomy specimen. So this sampling, although may not help in PT classification or stage assignment, the size of DCIS is an important factor in patient management. Extent is an estimation of the volume of breast tissue involved by DCIS. Mammographic assessment of DCIS, usually based on distribution of calcifications, may frequently underestimate or sometimes overestimate the extent of DCIS. So apart from the other findings which I had described in needle core, the CAP protocol also tells us to comment in a mastectomy specimen of margins. So margins, if DCIS is present at the margin, the extent of margin involvement is associated with the likelihood of residual disease. So how do we assess the margins? We call it focal involvement of the margin if DCIS is at less than 1 millimeter in one block. It is moderate if it is between focal and extensive, and extensively involved margins would be if it is in an area of more than 15 millimeter or in more than 5 LOPA fields, or in 8 or more blocks. In the American Joint Committee on Cancer and the UICC TNM classifications, DCIS is classified as TIS. The stage is not altered by grade or the expression of hormone receptors. And it is noteworthy that lobular carcinoma in situ of any type is not classified as PTIS in the AJCC systems. Of course, the lymph node sampling again. Why is it important? Now, patients with DCIS may have lymph node sample in the following situations: when there is extensive DCIS, when the pathologic findings suggest microinvasion, and imaging findings show, along with the calcification, there is an irregular mass or a large palpable mass showing likelihood of stromal invasion. And when it's a planned mastectomy, we sample the nodes so that even if invasive carcinoma is found later, another surgical procedure for node sampling is avoided. So why a frozen section is requested in a case of DCIS? One, for margin assessment during breast conservation surgery. Two, to rule out invasive carcinoma, though this is very occasional and I haven't done it yet. The limitations are that the freezing of breast tissue with high adipose tissue content is difficult. And DCIS often spreads in a discontinuous fashion. For example, if it is a BCS and we might say that the margin is clear, but the DCIS has a tendency to present as skip lesion, there might be a focus sitting 1 centimeter away. So freezing distorts epithelium and basement membrane, so it may look like a pseudoinvasion. And of course, the entire circumference of the specimen cannot be examined in real time. We just see few sections which appear close to us on cross examination. So coming on to the last section, that is, how do we integrate all the tools, including the clinical, pathological, and radiological findings? So step one, we start with core clinical pathological assessment, which includes all these clinical epidemiological features like age, nuclear grade, and the list as we see in the list. So the clinical decision at this stage would be what kind of surgery can be done and whether there is a need for re-excision if the margin is less than 2 millimeter. Further down, if the nomograms have been introduced, which look for the personalized risk assessments, and they refine risk beyond crude clinical pathological parameters. The common tools are MSK-CC DCIS nomogram and Van Nuys prognostic index, which I believe are not not into clinical practice yet. They integrate decisions in following way. If the predictive recurrence score is less than 10 to 12% without RT, we can consider excision alone. However, and if it is more than 20%, RT is strongly indicated or recommended. The next step would be to include the genomic assays when management is uncertain, like the upcoming Oncotype DX DCIS score. I don't know, most of the institutes are not doing, but I had inquired about it. The advanced modeling company is doing it, and they say we don't have enough samples in India, so we are not procuring them for this place. So I would like to definitely know opinion of the faculty on this test, the genomic tool, that is Oncotype DX DCIS score. Next would be to integrate ERPR and endocrine therapy decisions for ER positive DCIS. Then we consider the radiological features, wherein we look for the gray features like non-mass enhancement and multifocality to take a decision on BCIS versus mastectomy. So the composite risk would divide them into a low risk DCIS, an intermediate risk DCIS, and a high risk DCIS. So this is one of the current treatment plans which I got from one of the articles. And this considers, along with the other features, it also considers the positivity of BRCA and I think the Oncotype DX, etc. Thank you. I think I finished on time.
Thank you, Dr. Kavita. It was a wonderful lecture. We'll now move towards the next session. B3 lesions or breast lesions with uncertain malignant potential. So actually it is a gray zone between the benign and the malignant, and the diagnosis is often very complex. To navigate through this uncertainty, we have with us Dr. Tanuja Sheth. Ma'am is professor and head of the Department of Pathology at TMH. Over to you, ma'am, and your slides are visible.
Thank you so much. Is the full screen done?
No, ma'am.
Now?
Yeah, it's there.
Okay. At the first outset, let me thank Vaishali, Dr. Goyal, and all the team for inviting me to this webinars. It's always a pleasure to be here. So I always show these bridges. I think today is the era where we need to talk to each other. So these bridges are where pathologist goes to a clinical unit and tries to describe what he or she is observing. So that's me on the cycle, though I don't ride a cycle so frequently. So what are B3 lesions? B3 lesions are category, basically this is a very British word. It is a category of breast lesions that have uncertain malignant potential. It's not a gray area. It's a very well-defined area. It is not something that people are used to recourse to. These are definitely not benign, but they're confirmed, but you can't call them malignant. Why? Because number one, these lesions are very heterogeneous. So, you don't know what you're dealing with. They're often screen detected, and they're associated with increased risk of cancer. And most importantly, when we initially evaluate these lesions, we are looking at smaller size of lesions. So you don't know you have to put them in the perspective, what is happening in the rest of the breast. So we label it as, it's the British way of saying, oh, not so bad. So that's what it is. And that's exactly the B coding system that the UK NHS breast screening program has written, that you have a normal, you have a benign, and you have a malignant, and you have the not so bad in the middle, which is the B3 lesions. So if you're talking about a B3 lesions, all pathologists are recommended to talk about whether there's atypia or not. Because if there is atypia, then your incidence of detecting DCIS is around 11%. The invasive incidence remains the same, because invasive cancers are a totally different ballgame. And I'll come to that. Why is there not an upgrade of invasive lesions when you look at atypia? But definitely incidence of DCIS is more in B3 lesions with atypia. The lesions that typically constitute B3 are all the intraductal lobular proliferations of TDLU. And I'm glad that Kavita has already made some ground for this part of the story. Radial scar and complex sclerosing lesions, papillary lesions. I am not going to talk too much about spindle cell lesions and fibroepithelial neoplasm, because Dr. Hitoda is here to talk to you about it. So what Kavita showed a similar point of view, but just in an animated version, that the breast is made up of a TDLU and large ducts. In the large ducts, you have the little uncommon proliferations, that is the papillomas and intraductal papillary, whereas the chunk of our breast pathology comes from the TDLU and the SNI and the TDLU. And what are the chunk? You have fibrocystic change, you have columnar cells, you have all the epithelial proliferations, which are SNR, lobular neoplasia, fibroepithelial tumor, and even invasive carcinomas are thought to come from this part. And that's why we don't use the invasive duct carcinoma thing anymore. So just two things that everybody who practices breast disease needs to know, that we use two stains very commonly. One is cytokeratins and the second is the myoepithelial cells. Now, why do we use cytokeratins? I mean, it's frankly epithelial. What is cytokeratin? They stain the epithelial cells. So in the breast, there are two types of cytokeratins. The one, all of us know that there's a luminal cell and there is a myoepithelial cell. Now, in the luminal cells, you have 18 being expressed, and in the myoepithelial cells, you have the 5-6 being present. Now, why do you need this proliferation? It's very important in intraepithelial proliferation to say that in this mass of cells, if there is a good admixture of both these cells, then it's benign. But if one of them is dominating, then it's likely clonal and it's likely to be something omnious. So that's why we use it. The commonest thing all of you know is myoepithelial cells. We use a nuclear marker because this is how myoepithelial cells are. They are like flat cells. So if you take only the nuclear marker, there will be gaps like you can see here, and then you won't be able to make out invasion. So we use a marker for the basal lamina, and that generally is a smooth muscle heavy chain complex. So this is a P63, and that's a smooth muscle heavy chain complex. So to me, intraepithelial neoplasia actually is only two types. We use grade DCIs, we grade everything as high grade, low grade, intermediate. The intermediate is actually a pseudo category. So the low grade neoplasia comes from the TDLU and that kind of pathway, columnar cell lesions. It is not itself capable of becoming invasive, but it is associated with high incidence of luminal cancers. On the other hand, the HER2 positive diseases, which are associated with chromosome 7 anomaly, those are the ones that come from Cobido type of DCIs, and they have the DCIs itself has a propensity to invade, and this is my hypothesis validated by some of these studies that I have quoted here. So let's look at the duct part of the story. So in the duct part of the story, you have a duct with luminal and myoepithelial cells. Imagine the duct gets irritated. These green ones are the myoepithelial cells. They jump in and they kind of fill the lumen to stop the irritation. And that's why when you have a usual ductal hyperplasia, you have a good admixture of luminal and myoepithelial cells. Now imagine when you have hyperplasia, it's a ground for mutations. So then they develop mutations and that becomes something which is atypical because now it is ground, and these cells become very, very uniform with myoepithelial cells receding. That is called atypical ductal hyperplasia. Now, atypical ductal hyperplasia is actually low-grade DCIs or DCIs already. We call it atypical because it has to be in a substantial amount to call it DCIs. So if it is not more than 2 ducts, we call it ADH. So ADH is DCIS. And as I already told you, some high-grade DCIs have the capacity to invade, and that's the whole spectrum of intraductal proliferations. And as I said, that ADH, if it is greater than 2 millimeter, it's a clonal proliferation. It uniformly expresses ER, so it's quite close to DCIS. That's the story. So that's to show you that this is usual ductal hyperplasia, this is atypical ductal hyperplasia, this is DCIS. So in UDH, it's a very haphazard proliferation. Why? Because it's a mixture of both types of cell, nobody dominates. Whereas in the DCIS, you see this kind of a picture where you see one type of cell, luminal type of cell proliferating. If I do a luminal cytokeratin, only luminal cytokeratin work. Whereas in a UDH, it's a mixture of both the cytokeratins, and in a ADH, you have clonal proliferation, but usually 8-18 and very little of CK5-6 and CK14. So all intraductal proliferations, usually on smaller materials like BAB or colonidal biopsy, are classified as ADH. We don't use it at ADH, we use atypical ductal type of intraepithelial proliferation. Mind you, I again stress that the difference between ADH and DCIS is quantitative, and ADH is associated with the increased risk than usual ductal hyperplasia. So here is a wire localization for mammographically detected abnormality. What do you see? You see a cluster of ducts and you see that there is something going on. And I think even the non-pathologists in the audience will realize there are two types of cells. You have these plump looking cells, which are the luminal cells, and actually what is inside is small cells. So you already know these are myoepithelial cells and you're not worried about the lesion, but for the purpose of this lecture, we add a CK5-6 and you see that a large amount of that proliferation is rich in CK5-6. So you call it usual ductal hyperplasia. Now let's look at this lady who had a IBC and she was on follow-up. There was a microcal. So VAB was done. This is just one part of that VAB. And we saw these 3 ducts filled with atypical cells. Now, if you look at it, you can see there's a distinction. These cells are a little different than this cell. So yes, there is heterogeneity. That one is a little more uniform. But so I'm worried. So I do some markers. What markers I do? I obviously do a CK5-6 and you see that there is what is inside the lumen is not having CK5-6. So I'm worried The estrogen receptor is strongly and diffusely positive. So yes, I called it ADH or atypical ductal intraepithelial proliferation. And on the excision, there's nothing. So we continued calling it ADH, though this was a cluster of 4 ducts, because the size of a lesion is very, very small. So this is the kind of dynamic discussions that you have to have when you're dealing with lesions like this. Now we come to the lobular part of the story. And in the lobular part of the story, what do you have? You have this normal breast where there is a luminal lining and these nice clear plump cells are your myoepithelial cells. This is a reproductive breast. So the myoepithelial cells show you these secretory kind of changes. When this atrophies, the myoepithelial dies. And because there's nothing, this is what is fibrocystic change, because the luminal cells have no support, they're non-proliferating. And anything is that not proliferating is also a source for mutations. So what you get is a columnar cell change, which is the first step towards neoplasia in breast cancer. And if that proliferation, acinar proliferation, forms a mass, it's sclerosing adenosis. And if it is little more complex and like what I call this khichdi, then it is a radial scar. So let's look at the columnar cell continuum. So what is columnar cell change? If you remember, the breast epithelium is very flattened like this when it atrophies. Here, this is not an atrophy, but it is an it's pre-neoplastic conditioning of cells. So the cells become, instead of flat, they become apocrine with this snouting. And because there are snout, they develop calcification, and most common lesion that ever comes on a radiology. Now imagine this particular pathology remains. You get hyperplasia added on this. So you call it columnar cell hyperplasia. And when it remains for a longer time with more mutations, mitosis, we call it flat epithelial atypia or columnar cell. This can be called variably. Now there's a huge variation in terminology for these units. So you can have flat epithelial area DCS. And there is this JAMA article where the same lesion was called by 15 pathologists differently, and the patients chose different kind of action because the pathology label varied when the slide actually was showing the same. So personality of pathologists gets intertwined in what we call in the diagnosis, sadly, based on your experience or eminence. So immunohistochemistry, so what is a more evidence-based thing of doing it? We use a set of markers. The markers I commonly use, I already told you about basal cytokeratin. I use ER and cyclin D1. Now this is based on some very old publications. The recent papers don't talk about it, but I somehow feel that something is better than nothing. So I use these 2 markers, and as you grow higher in the grade of any intraepithelial proliferation, there is a loss of basal keratin and there is a increase in cyclin D1 ER. So that's the whole story. And so let's look at a couple of lesions. So this is a screen detected breast lesion, the small focus like that. You can see there is atypia. Now, when we talk of atypia, it's nuclear atypia. The architecture is really, really haphazard. But remember, this is screen detected. There's a perspective issue. So what we do is we put 2 stents, ER and cyclin D1. Now, you look at the ER and cyclin, they're heterogeneous. That means not every single cell within that proliferation is positive. So it tells you there is a mixture of epithelial, myoepithelial cell. So what we do is we call this as usual ductal hyperplasia. On the other hand, this is again a case of CA breast on follow-up, and this was a VAB done. And you can see there's a huge cluster of microclals, which was very suspicious. And if you look at the scanner, it's very scary because of the calcification. But when you go on the higher part, you see, yes, this is a reasonable sized lesion with a lot of calcification. But the atypia is not vorumlani. There's no mitosis, there's no necrosis, there's just calcification because of the secretions. And there is mucin, which bothers some people. But as I said, there is atypia. So what we do CK5-6, the ER was diffusely strongly positive. So we did call it as ADH, as you will, and at that point of time, and there was nothing but nothing elsewhere. So we observed this patient, and the 1 year follow-up is, in fact, the lesions have decreased and the abnormality is substantially less. So just to tell you that don't worry of atypia, this is a pathologist's bread and butter, especially with many mammographies being done. So papillary lesions. Now, these are a huge problem. I think all the court cases about pathologists have been for papillary lesions, whatever little I know. So why? Because number 1, the usual papilloma, central papilloma, single papilloma with nipple discharge is pick up. But the peripheral papillomas, they tend to produce solid masses because of cell proliferation. They tend to entrap structures around it. They start mimicking invasive carcinomas. They are prone to needle track displacements, and atypia is natural to in a papilloma, and then you worry about it. So I just want to, this is a crude cartoon from my side, that this is a papillary lesion. A papillary lesion has a vascular core. And you see that this is the blood vessel, that is the light blue. And what happens is, if it gets irritated because it is in this fluid, the myoepithelial cells go and kind of fill the spaces, and the whole lesion becomes solid. And if you do a core biopsy from this, the pathologist is not only going to recognize it as something benign, and this is exactly what this case is. It was called as IBC solid variant because it was a solid lesion. But when we did CK56, it was loaded with CK56, so it's nothing but a papilloma with solid myoepithelial kind of proliferation. This is another problem that happens, is that glandular structures dip in from the stalk inside the stalk, and pathologist thinks that it is invasion. But remember, the invasion is not expected here. It's not even expected here. It's expected way beyond the wall of the papilloma. So if you get a very tiny thing in the invasion in the wall of a papilloma, your spider sense should start tricking. So this is just to show you how difficult sometimes papillomas look for the pathologist in the audience. So we use myoepithelial cells and CK56 very liberally in papillary lesions. A usual papilloma has myoepithelial cells at the base of each of the papillary core, and it has it in the wall of the whole cystic structure. There are two entities which are very unique in the breast. One of them is encapsulated papillary carcinoma. What is this entity? This is a cyst with a cancer inside it, which lacks myoepithelial cells, but it is still called as DCIs. Why? Because everything is within that wall of the cyst, and we'll see an example. The solid variant of papillary carcinoma is another unique entity where everything looks like DCIs, it behaves like DCIs, but when you do myoepithelial cells, you will not see myoepithelial cells at the periphery. So clinicians should understand the complexity of the papillary lesion to understand what to make of it. You also should understand that these are very heterogeneous. So in a papillary lesion, if you do biopsy from the periphery, you'll get only cystic fluid. Now, the atypia in the myoepithelial often is mistaken for a carcinoma. In an encapsulated papillary carcinoma, if your biopsy goes, remember there are foci, or if there is a papilloma with DCIs and your needle goes through a papilloma, we'll call it papilloma if you go it. So that's why sometimes entire lesion excision, whenever there is atypia, is very important. And sometimes you have invasive carcinoma sitting next to a benign papilloma, so you have to be variants of that. So this is a typical papilloma. Everything, all the fronts of the papillae, they fit into a nice closed jigsaw puzzle. And you see, it's like a mass. It's a nice mass. There's only one point of attachment. That's a beautiful papilloma for you. But this is how things get complicated. Both these lesions don't look cystic at all. Both are papillomas. On one side, you can make out some cyst wall. So maybe somebody is thinking of a papilloma. But this lesion here, you will never think of a papilloma until you realize that there is a duct at the periphery of some other sections, which I'll show you soon. So again, the same thing. Now, in the region these are two different lesions. On the right side, you see that it's very monomorphic, whereas here you can see there's a mixture of cells. And on the right side, you start seeing DCIs at the periphery. So you're already worried about this lesion. You go ahead, in the left side lesion, you see a very beautiful biphasic lining. That's the luminal cell. That's your myoepithelial cell. So those you know is benign. Whereas this guy is very, very monomorphic. You have very, very tiny papillae. When you look at the duct wall, on the left side region, you see a very flattened benign lining. Whereas here, everything is the same. So you know there are multiple point of attachments. There are in the right side lesion, whereas my right side, whereas this lesion has only one, everything is stuck to the wall, but you have very benign lining. So that if you have a benign duct wall lining, that lesion is benign. So we do myoepithelial markers. It's very abundantly present in the left side region. On the right side regions, they are not present because it's an encapsulated papillary carcinoma. Now let's look at this VAP. And you can see there are two different areas. This lesion, maybe I will think that this is again not looking very papillary because it's a solid proliferation. And if you see, I'm worried about these two areas, this area and this area. Why? Because they are monomorphic. So anything in a papilloma that is monomorphic worries us. So we do the CK56 in that one area. It is entirely 818 ER positive. So this is a worrisome lesion. We call it as a ADH in a papilloma, and final excision, it was a papilloma with DCIS adjacent to it. So my guess is that this is also a DCIS. So I think I have some couple of minutes remaining. So I'll just quickly go through this case. Now, in this particular case, you can see this was a very benign papilloma. And there was an invasive carcinoma sitting in the wall of the papilloma. One of my colleagues, Dr. Trupti, saw this and she got worried because she's saying the papilloma is benign. Why is there's an invasive carcinoma in the wall? So we just looked at it. It was a little scary lesion. Yes, it looked micropapillary, it looked invasive, infiltrating at all. And then suddenly it struck me that this is after all a papilloma. It can do very weird things. So we just asked for history of core needle biopsy. And mind you, the myopithelial cells were lost in that. And this was nothing but a horrendous case of needle tract implantation. So somebody had a wide gauge core on her. And what we saw was the epithelium going to and producing something like a needle tract transplant there. So be very careful when you have small invasive tumors in the wall of a papilloma. The chances of them being implantations are very good. So coming to the complex epithelial proliferations. Now, why do they mimic carcinomas? Pathologists make a mistake here also. Why? Because these are mass forming and they are infiltrating. But there are three important clues that they don't carry much of that stroma or elastosis that invasive breast cancers carry, and there is no mitosis of necrosis. So let's look at a couple of lesions. So this is a core biopsy, a mass forming infiltrating lesion. And when you go on the high power, you see atypia. But it's very important to understand that this atypia is in the apocrine looking cells. So this is the pitfall in most complex lesions, that atypia, all apocrine cells are dying. They naturally carry an atypia. So that is why spider sense telling me, no, this is not malignant. So we do myopithelial markers and they are plentifully present in this lesion. This is a sclerosing adenosis. Now, in the final excision of this, we tend to excise mass-forming sclerosing adenosis because surprises are very usual. So in this case, you can see the infiltration of the cellular adenoma. This is the benign area. And this was the lobular neoplasia seen in one of the sclerosing adenosis. So that's the problem with sclerosing adenosis. Now we come to what I call as a khichdi in breast cancer. This is a lesion that has everything that breast pathology shows. Number one, it will show you sclerosing adenosis. Number two, it will show you papilloma. It will show you fibrocystic gel and a central, very proliferating tubular element, which somebody might just call it as tubular carcinoma. So that's your radial scar. And when it's a substantially hard, big lesion, we call it a complex sclerosing lesion. Now, this lesion nobody thought was a sclerosing, radial scar because, it was not cut in the perfect, nice, flowery pattern. But this was a radial scar and we had epithelial proliferation within that radial scar. We looked at it. So what are the two stains we'll do? Very clear. We'll do one myopithelial cell and we'll look at CK56. Now, if you look at it, CK56 tells you it's totally absent within that clonal proliferation. And the myopithelial cells, of course, we just put it for namesake. There was no question of invasion here. The ER was strongly positive, but the cyclin D1 was again heterogeneous. So HER2 was negative. This was the only focus. So we did call it as ADH in a radial scar. Now, in the ADH in a radial scar is associated with some amount of upgrade in the final excisions, but this was the final excision. This patient we have been following for a long time. Remember that you should understand that if it is multifocal, it is associated with necrosis, and it is seen in more than 3 cross sections, you will call it as DCIS and not ADH. So that's the whole story about DJS and DCIS. Now, just one quick word on fibroepithelial tumors before I close. That for the diagnosis of phyllodes tumor, we need 4 criteria. One is, I have not talked about capsule because that varies according to the subtype of phyllodes tumor. We need stromal overgrowth, which is at 10x or 4x, stromal cellularity, atypia, and mitosis. Now, when you do a core in a fibroepithelial lesion, what happens? You don't see the overgrowth because your needle might have gone from an area where there is no overgrowth. The cellularity, because of the fixation, sometimes is not very high. And again, you might have gone into the less cellular areas. And the atypia also becomes very shrunken in a core biopsy. And that's why core biopsy tends to downgrade fibroepithelial lesions. For the want of time, I'll just show you one case. Now, this is a nice core biopsy. And you see, so normal fibroadenoma showing lots of this collagenous spring stroma. Here what is happening, you're seeing blue areas. These blue areas are the cellular areas. So yes, as a pathologist sitting here, and you see this is a representation of a leaf-like space. We call it as a fragmentation, where you have one core with 2 sides covered by, so it's a leaf. So you have 2 sides covered by epithelium. So that's the kind of thing you have. So yes, you're thinking of a phyllodes tumor and there is enough atypia. There is low mitosis, so you end up calling this as, so there is cellularity, there is no overgrowth, but there is mitosis, so you end up calling this as a benign phyllodes tumor. And in the final excision, you see a much more number of mitosis, and you realize that this is a totally different tumor what you got on the core biopsy. So that's the problem with phyllodes tumor. That's the reason they become B3 lesions. So to conclude, the spectrum of B3 essentially represents tumors that are often associated with a high chance of upgrade after a corneal biopsy. And the most common B3 lesions are intraepithelial proliferations and mass-forming complex sclerosing lesions, phyllodes tumors and papillary tumors. And I think this is one lesion, this is one entity in pathology, wherever we are, radiology, oncology, which requires teamwork and discussion before you do final surgery. They will continue to remain a challenge, but with the continuous audit, you have lesser amount of B3s, very clear guidelines on management. And I think after all, pathologists are Spider-Mans, and the blue and the reds are the radiologists and the surgeons. So what you feed me is ultimately what I decide from the B3. Thank you so much.
Thank you, ma'am. Now we'll move towards the next session. So here we'll be discussing a subgroup of breast cancers which actually have very favorable prognosis. To discuss it, we have with us Dr. Ruchika Goel, Dr. Ruchika Goel is Associate Director of Oncopathology at Medanta. Over to you, Dr. Ruchika.
Is screen visible?
Yeah, it is. Please do it on the screen, that slideshow mode. And my request to the speakers, Tanuja ma'am and Dr. Kavita, please stay with us so that we can discuss the question and answer session at the last.
So good evening. I thank the organizers, Dr. Rajiv Agarwal, Dr. Goyal, Dr. Vishali for having me here. So quickly, we'll be discussing some of the rare types of breast cancer. And since Dr. Tanuja has already shared quite elaborately the structure, I'll directly now deep dive into the main. So why is it essential to discuss these rare tumors? The management of these lesions is controversial since these are very rare and we do not have substantial guidelines still which can define their treatment. And since the incidence of these tumors is rare, therefore it is important and imperative to diagnose them and have uniform guidelines for these. Now, a role of a pathologist has evolved over the years, not from just being a simple diagnostician. We have markers which help in prognosticating a disease. And now we also have certain molecular genes which can tell us as to what kind of therapy which will help a patient. And thus, we also play a part in now the precision medicine. Now, a breast cancer pathology report, there are few prognostic markers which are very essential, and we are all aware about them. And some of them are the histological subtype, molecular subtype, lymph node status, DCIS, LVI. So today we will be discussing some of the rare histologic subtype of these tumors. The 5th edition defines invasive breast carcinoma and gives about 20 different histological subtypes of these tumors. Based on the molecular subtyping, we are all aware that breast cancer is divided into 4 main categories: the luminal A, luminal B, the HER2-rich, and the triple negative. So generally, it is the luminal A ones which are associated with good prognosis as they are ER/PR positive. So coming on to some of the rare luminal A type of breast tumors. This was a 50-year-old female who had a postmenopausal, who had a family history, no family history of malignancy, and a lump in the breast since 2 months. So this was a mammogram with the lump, isoechoic mass on ultrasound. And what do we see? We see nests and strips of neoplastic cells floating in pools of abundant extracellular mucin. Again, these tumors are associated with DCIS. The nuclear atypia is quite mild. It can be mild to moderate with an occasional mitosis. So to call it a classical mucinous carcinoma, you need to have at least 90% of mucin component. And if you have that, they are generally ERPR positive, HER2 negative. So good tumors, favorable prognosis. What gets challenging is when we come across variants of these tumors. So at times you can have tumors like this. They are mucinous, they have abundant extracellular mucin, but you have severe nuclear pleomorphism, brisk mitotic activity. They are ER negative and HER2 positive. Or at times you can have micropapillary variants of mucinous carcinoma. Now again, these tumors are ER negative and HER2 positive. They're seen in the age group of younger compared to the conventional mucinous. They're associated with lymph node metastasis. And these are aggressive tumors. Also, at times, you have a metaplastic carcinoma, which can produce abundant chondromyxoid matrix, which can mimic mucinous carcinomas. But remember, these would be triple negative. And they are high grade. So these are not mucinous carcinomas. So when a diagnosis of mucinous carcinoma is made by a pathologist, as a clinician, what should you ask the pathologist? Is it pure mucinous or mixed? And now why is that essential? This is important because we all are aware that mucinous tumors are normally low nuclear, ER positive, and Mets to nodes is comparatively rare. However, the variants or the high-grade type, or when you have a mixed type, these are smaller tumors, occur in a comparatively younger age group, and there is high chances of axillary metastasis. So it's these mixed type of tumors which will require further therapy. And what are these mixed tumors? These mixed tumors are the ones which have mucinous carcinoma along with your IDC or some other component with it. So now here your mucinous component will be less than 90%. So it is a good practice for a pathologist if you're seeing two different types of invasive carcinomas, ideally give the percentage of each tumor. It will help the clinician to know how the tumor might behave. Now, we all are aware that tumor size is supposed to be an important prognostic marker for staging. But this has been challenged in literature for mucinous carcinomas. Because of the abundant presence of mucin, these may not be able to predict the exact size of the tumor. These tumors are known to be ER positive, but do you think Oncotype DX or a mammoprint can help in these tumors? Now, these genetic tests may not be useful for these carcinomas because of the excess of mucin. The RNA extraction gets difficult and the report can be compromised. Why is it essential to differentiate the mucinous and the mixed? Because the mucinous carcinomas overall have a better prognosis compared to the IDCs. Also, lymph node metastasis is rare, and if it's there, generally nodal involvement is less than 3 nodes. However, if there is node involvement, then the prognosis of these tumors decrease, and they have comparatively poor outcome. Coming on to our next case. So this is case 2, where again, we had a small lesion with spiculate angulated radiating margins. And on histopathology, you see these tubules in the desmoplastic type of stroma. So this is a classical tubular carcinoma. What is essential is to differentiate tubular carcinomas from grade 1 IDCs. And how do we differentiate them? One is that the tubule formation here would be more than 90%. Also, the tubules here are generally angulated. Okay, they will have apical snouting. And the nuclei here are quite low grade. Your IDC nuclei can be a score 2 also, but these are generally score 1. And your Nottingham's histological score would generally be around a score 3 or 4. Myoepithelial cells are absent, and these are ER positive. They are generally small size, can be associated with microcalcifications. Lymph nodes are generally absent. So a simple breast conserving surgery with a sentinel lymph node biopsy can suffice for treatment. And prognosis is better than IDC. However, one should be careful as to not confuse tubular carcinomas from grade 1 IDCs. One point of concern in tubular carcinomas are that there is high incidence of development of a contralateral breast carcinoma, and that can be as high as 25%. So it is imperative to also equally evaluate the other breast and also during the follow-up. Also, at times, tubular carcinomas are known to exist with a lobular component, and you might have a tubular lobular carcinoma. Now, those kind of tumors will have a poorer prognosis compared to a classical tubular carcinoma. Another type of luminal A tumor with excellent prognosis, just like your tubular carcinoma, is your cribriform carcinoma. This is again a grade 1 tumor. Normally, it's classified into pure type or a mixed type. Now, pure type is where you have the cribriform pattern in more than 90% of the tumor. So you can have these rounded islands in a desmoplastic stroma. You have these punched out spaces, which is also known as the sieve-like pattern. Closely mimics a cribriform DCIS, which you've just seen. But how do you differentiate it? You can do a panel of markers, and all your myoepithelial markers will show loss around the periphery, which demonstrates the invasiveness of this tumor. However, these are good prognosis, and associated, the overall survival is way better than IDC grade 1. And long-term survival is more than 90% in these tumors. So again, here, a simple surgery, because generally they are small in size, along with a lymph node sentinel examination can suffice, and systemic therapy is generally not required for these tumors. Coming on to our next entity, the low-risk triple-negative breast carcinomas. So generally, there is a misnomer where we think that all triple negatives are supposed to be high-grade, aggressive, with poor prognosis. Now, that is not the case with all triple negative. There are some of the triple negatives which might have a favorable prognosis. And some of these are the salivary gland type tumors, like the adenoid cystic, the secretory carcinomas, the tall cell variant, or the apocrine carcinomas, tumors which are rich in tumor-infiltrating lymphocytes, and even small size tumors, that is tumors which are less than 1 centimeter without node involvement, even triple negative, may have a favorable prognosis. So let's study some of these entities now. She was a 53-year-old premenopausal woman who came with a lump in the breast, long-standing 3 to 4 months duration, a large isoechoic lump. And what do we see? So just see this mount view showing a totally circumscribed border. So these tumors were earlier mentioned as medullary carcinomas. Very circumscribed borders. Even grossly, these tumors have pushing margins. Tumor cells are in sheets with a rich lymphoid infiltrate in between them. Again, tumor cells in sheets, moderate to severe nuclear pleomorphism. You can have prominent nucleoli. They may be brisk mitosis, high number of tumor infiltrating lymphocytes, and they are triple negative, ER, PR, HER2 negative. What happened? Why did this entity disappear? So what was happening was a number of IDCs grade 3 were being wrongly labeled as medullary carcinomas. Now, IDC grade 3 prognosis is inferior to that of a medullary tumor. And because of this confusion and misdiagnosis, it was decided that this entity called medullary carcinoma would be removed, and the WHO decided to add a medullary feature to the term IDC. So now if you see a tumor like this, they're called as invasive carcinoma with medullary features. So the term medullary carcinoma has been removed, and now it is considered as part of IDC, but you add an adjective saying that these are the medullary features that are present. However, if any of these features are not present, for example, your syncytial growth or circumscription, then it comes into the atypical features. Next type of a triple negative tumor, which belongs to our salivary gland, is your adenoid cystic carcinomas. Now, adenoid cystic carcinomas, these are very similar to what you see in the salivary gland. They will have the similar pattern. Your cribriform pattern may be there, or you may have a tubular pattern. These are made up of epithelial and myoepithelial cells. Yes, an invasive carcinoma where myoepithelial cells are present. And you will have spaces like these, which will have these pseudoluminas with basophilic secretions. Nuclear pleomorphism may be mild to moderate with mitosis. So adenoid cystic carcinomas are divided into three main types. You have the classical type, the solid basaloid variant, and adenoid cystic carcinoma with high-grade transformation, which has the worst prognosis. Classical type has the best prognosis. CD117 IHC can be used to clinch the diagnosis. So this is one of our cases, again, which had both the cribriform pattern and the tubular pattern. So classical adenoid cystics have favorable prognosis. They do not have perineural invasion usually. Lymph node metastasis is also very rare. However, the solid basaloid variant, these are the ones which have chances of perineural invasion, axillary lymph node metastasis, and at times distant metastasis to the lung, skin is common. And now these types are the ones which require systemic therapy. Your classical ones may require only surgery with sentinel lymph node. Systemic therapy may not be required. However, grossing extensively and identifying sections to look for areas like this is essential to rule out the solid basaloid variant, as these have inferior prognosis. Next type is a secretory carcinoma. Very, very rare tumor. Earlier thought to be seen only in children, young adults or adolescents. However, now there have been cases reported even in adults. They have a good indolent cause, but in elderly population, lymph node metastasis has been seen, but yet they have favorable prognosis. Now, generally on radiology, they are known to be circumscribed, very well demarcated, can mimic fibroadenomas. Thus, it is essential that when you see women with circumscribed masses, especially in young age group, one should not leave them just as fibroadenomas, because you might be missing on a secretory carcinoma, even though they are very rare. So what is the pattern? They generally have this microcystic type of a pattern. You may have some cribriforming in tubular areas. You have intracellular and extracellular mucin. The cytoplasmic vacuolization is common in these tumor cells. The nuclear grade is generally low, and the mucin can be demonstrated with PAS and Alcian blue. They are S100 positive. They are triple negative, but at times weak ER staining may be noted. What is pathogenomic of these tumors are? The ETV6 NTRK3 gene fusion is always seen in these tumors, and this can be demonstrated using an RT-PCR of FISH. However, now there is an antibody which is called the pan-TRK IHC, which can also be used to identify these tumors. Now, axillary lymph node metastasis is generally not seen in the young adults, but in the elderly age group, node involvement is seen, which can be as high as 30%. even though the nodes are few, less than 3 nodes involvement is seen, and yet prognosis of these tumors is good, even with nodal involvement. There has been rare cases which have shown metastasis, and in those cases, systemic therapy is required. There is clinical trials going on saying that tyrosine kinase inhibitors may have a role in these tumors. However, again, because of rarity of these tumors, there are no definite guidelines as to the standard management of these tumors. A new kid on the block, tall cell carcinoma with reverse polarity, included in the 5th edition of WHO, just mimics your papillary carcinoma of the thyroid. Less than 100 cases have been reported till now, generally seen in the 6th to 7th decade. So what are these tumors? So these tumors have these solid cystic type of spaces with these papillary proliferation, and you have these columnar type neoplastic cells around these fibrovascular cores. They look like a papillary carcinoma. Occasionally, nuclear grooving or an optically clear nuclei might be seen in these tumors. These tumors are positive for both your low molecular and high molecular weight CK, that is your CK7 and CK5-6. Myoepithelial markers are absent around the periphery of these lesions, thus showing the invasiveness of this tumor. And because the nuclei are so apically located, when you do a MUC1 staining, you have this classical brush border appearance. So normally, even though the nuclear pleomorphism may be moderate to severe in these tumors are known to have a favorable prognosis and indolent course. And however, we have less data in literature, only 100 cases till now. But out of this, only 1 case has shown metastasis till date. So Dr. Tanuja has discussed papillary lesions in detail, but I've just included 2 of the papillary types because these are diagnostically challenging for the pathologist. What are these? One is your classical encapsulated papillary carcinoma. So what are this? This is tumors which are arising in this cystic space. They have this fibrous capsule, and you have this papillary tumor with fibrovascular cores arising within this space. The nuclei are generally perpendicular to the fibrovascular core, mild to moderately pleomorphic. What is common in these tumors, or what gets challenging, is just like ma'am mentioned earlier, is sometimes we see this. You have this at the periphery of these lesions. This is called as epithelial displacement, commonly seen with these papillary tumors because of repeated either FNAC or core biopsy. But what should you look when you see this? Do not overdiagnose this as invasion. Look for the things around these tumor cells. What is accompanying it? You will generally see inflammatory cells, hemosiderin-laden macrophages. All this is because of the previous biopsy done. If you see neoplastic cells like this infiltrating into the fat without accompanying these inflammatory cells, desmoplasia, that is true invasion. So this is a common phenomena which is seen in these tumors. Myoepithelial cells are generally absent at the periphery of the tumors and within the lesion, as discussed earlier. So what should you call it? Are these in situ or invasive? So studies have shown that these tumors do show mets. They may be micromets, but even with micromets, they have favorable prognosis. They have an indolent course. This was a study done by Raka et al., who studied about 208 pure EPCs. And they said that even with mets, they have indolent course, and therefore they should be studied and they should be treated as in situ tumors, even though they have a lack of myoepithelial cells at the periphery. And that is exactly what the WHO also recommends. Continue to treat them as in situ lesions. Do not overtly label them as invasive unless you see an invasive component, because if you see an invasive component along with these tumors, then your TNM staging, that is your size of the tumor, your prognosis, everything will depend upon that invasive component. Another of these papillary tumors is your solid papillary carcinomas, seen in the 7th decade. Generally, tumors are located in central location, retroareolar, presents with nipple discharge, and you have these solid proliferation of neoplastic cells. LOPA give a cribriform pattern. You have abortive kind of fibrovascular cores. They are generally seen with mucinous carcinomas. Delicate network of these fibrovascular core, quite benign looking nuclei. You might have a granular eosinophilic cytoplasm. Myoepithelial cells might be present at the periphery of the lesions or might be attenuated to absent. And they are positive for neuroendocrine markers like chromogranin and synaptophysin. So this is again an in situ lesion, again to be treated just like DCIS, and excision followed with sentinel lymph node is the treatment of choice. And if an invasive component is not associated with them, generally systemic therapy is not required and they follow an indolent course. So just to summarize, we have defined some of the rare type of luminal A tumors, which were the mucinous, the tubular, the cribriform. Triple negative are also all that not bad. You have good tumors within them, like the secretory carcinoma, the classical adenoid cystic, the tall cell carcinomas. And in all these tumors, surgery followed with sentinel lymph node may be sufficient because they generally have a favorable prognosis and do not metastasize. However, what is important for the pathologist is you need to see subtle things in these tumors. Look for any variants of these tumors. Look for any discrepancies. Is there something that is not fitting into your classical mucinous? Is it a high-grade type? If you're getting HER2 negative, or if you're getting a HER2 positivity, then you need to specify that this might behave in an aggressive manner. And all these things need to be discussed with the oncologist, with the surgeon, because only when we discuss this as a team will we finally benefit the patient. And only these multidisciplinary meetings will finally help the patient. So teamwork it is. Thank you.
Thank you, Dr. Ruchika. Great presentation. Now we'll move towards our last session, which is about the stromal malignancies in breast cancer. And for that, we have with us Dr. Jyotsna, who is Associate Professor at Kochi, Amrita Hospital, Kochi. Over to you, Dr. Jyotsna.
Am I audible?
Yes, you are.
Yeah, and you can see my slides, right?
Yeah, make it on slide share. Yes.
Yeah, just trying to do that. Yeah, I hope I'm good to go now.
Yes, you are.
Yeah. So good evening. At the outset, let me thank the organizers for giving me this wonderful opportunity. So after elaborate discussions on DCIS, B3 lesions, and then the rarer epithelial tumors, now we come to the truly uncommon and unpredictable group. That is the spectrum of stromal neoplasms in the breast or the mesenchymal neoplasms of the breast. So anatomopathologically, probably we can classify breast tumors broadly as epithelial tumors, which are probably the more frequent ones that we encounter. Then we have the fibroepithelial group, which usually arises from the intralobular stroma of the breast. And then we have the much rarer stromal or mesenchymal tumors, which arise usually from the interlobular stroma. So for a general introduction, what all constitutes trauma? So it includes all types of soft tissue. It includes smooth muscle. It includes fibrous tissue. It includes nerves, blood vessels, adipose tissue, cartilage, bone, so on and so forth. So now, when you talk about the mesenchymal lesions of the breast, they could originate from either the mammary parenchyma per se, associated skin, subcutis, or the deep soft tissue. But they are very rare, constituting only around 0.5 to 1% of all breast tumors. And they are a very heterogeneous group. They have very diverse clinical, histomorphological, as well as molecular features. And the other important point to note is that most of them are not actually specific to breast. So any mesenchymal lesion arising in any extramammary soft tissue can also arise in the breast. But then we have probably a few unique ones, like your mammary myofibroblastoma and pseudoangiomatous stromal hyperplasia, which probably arise from the specialized breast myofibroblast. So this is a brief outline of my talk today. So I'll initially cover some general points on mesenchymal tumors of breast. Then I'll start off with the most important differential diagnosis of mesenchymal lesions, particularly the site-specific mimics, that is metaplastic carcinoma and Phyllodes tumor, which will keep popping up throughout our discussion henceforth. And actually, the list of mesenchymal tumors is very big and exhaustive. But for font of time, I'll be discussing the salient features of selected specific mesenchymal tumors, particularly the ones mentioned in the WHO Breast Tumor 5th edition. Then we'll just have a broad outline on the management. So, as already shown, this is our Bible, the WHO Classification of Tumors of the Breast, 5th edition. So this is the big list of mesenchymal tumors in the 5th edition. So as you can see, they classified into different groups like the vascular or the angiomatous lesions. Then you have the fibroblastic and myofibroblastic tumors. You have peripheral nerve sheath tumors, smooth muscle tumors, adipocytic tumors, as well as other mesenchymal tumors and tumor-like conditions. Now, in each of these groups, you actually have 3 different types of tumors based on their behavior. So there are benign lesions which are actually cured by excision like a lipoma. There are intermediate lesions, which could be either locally aggressive, meaning they could be really infiltrative, making them highly prone to recurrences like a desmoid fibromatosis. And in this intermediate category, you also have this group of rarely metastasizing tumors like the inflammatory myofibroblastic tumor. Then in each of these groups, you have the frankly malignant lesions, which have the properties of infiltration, recurrence, as well as metastasis, like your frankly malignant angiosarcoma, leiomyosarcoma, and so on. So usually at the clinic, these patients present with mostly painless breast masses with varying growth rates. And the usual triple assessment has to be followed. So on clinical examination, you get an idea of the size of the tumor, the depth of the tumor, and then the patient is sent in for imaging. Imaging again confirms the size of the tumor, the relationship of the tumor to adjacent structures. And at a later point, you will even need imaging techniques to look for metastasis. But if you go in expecting that imaging will tell you specifically which mesenchymal lesion this is, you'll be disappointed because there's a lot of overlap in the imaging findings. So the gold standard on which the final diagnosis results, final diagnosis rests is actually histopathology evaluation. So diagnostic sampling is usually done for these lesions by a core needle biopsy. Now, FNAs or fine needle aspirations are discouraged because they give you limited tissue, which may not suffice for ancillary studies, and it's very difficult to ascertain the architectural patterns and other properties of the lesion on fine needle aspiration material. So once we get a core needle biopsy on our table as a slide, what do we do? So as pathologists, you'd know we go from a low magnification to high magnification. At a lower magnification, we look at the broader picture in the sense we look at the tumor borders, we look at the overall cellularity, the cellular patterns, and the cellular compositions. And as we go to higher magnifications, we get to see the cells per se. So we look for cytologic atypia, we look for mitotic activity, and we also look for malignant heterologous elements in the context of mesenchymal tumors. But morphology on our routine light microscopy alone often doesn't suffice for this very complicated group of lesions. And so we resort to a whole lot of ancillary tests like special stains, immunohistochemistry studies, and sometimes even the molecular tests. But all these have to be thoroughly correlated with the clinical and imaging profile of the patient. So as pathologists, we have a lot of diagnostic challenges here because mesenchymal lesions per se are relatively rare and they are pretty heterogeneous. So with a core biopsy, we actually get a very small limited sample. And there is a lot of morphologic overlap with other commoner breast lesions when you're talking about mesenchymal lesions. Also, they have a very broad biological potential. They can range from reactive proliferations all the way through benign neoplasms to highly malignant sarcomas. And we know that accurate classification is quite crucial in guiding treatment in these cases. So we try maximum to give a definitive diagnosis, but there are certain situations when a definitive diagnosis may not be possible on a core biopsy material, in which case we tend to give a descriptive diagnosis with possible differentials so as to guide the treatment. And the definitive classification and nomenclature can probably be deferred to the study of the final excision specimen, where we have the luxury of sampling more tissue and studying more areas of the tumor. So just a few words of caution. So whenever you hear about mesenchymal neoplasms, the first picture that comes to your mind is probably that of a spindle cell tumor. But what you should understand is all mesenchymal neoplasms or stromal neoplasms are not spindle. But definitely, this is a very challenging group with significant imaging, morphologic, and immunophenotypic overlap with other mesenchymal as well as non-mesenchymal lesions. Now, just as I said that all mesenchymal tumors are not spindle, the converse also holds true. All spindle tumors are not mesenchymal. So you have to have a very broad differential diagnosis. The interesting fact is that the most frequently encountered spindle cell neoplasm in the breast isn't actually mesenchymal. It is a metaplastic carcinoma. So that brings us to this very important point, the site-specific mimics of mesenchymal tumors in the breast. So first and foremost, they are the primary breast metaplastic carcinoma and malignant phyllodes tumor. So what we should always remember is that these are much commoner than the primary mesenchymal neoplasms of breast. And so they must always be excluded before considering a primary mesenchymal tumor. So just a few words about these two site-specific mimics, because those are probably the lesions that you'll encounter much more frequently than the rarer mesenchymal tumors. So metaplastic carcinoma is a very heterogeneous group of invasive breast carcinomas wherein the neoplastic epithelium differentiates towards either squamous cells or mesenchymal-looking elements. Now, these mesenchymal-looking elements could be in the form of high or low-grade spindle cells, or they could have heterologous chondroid, which means cartilaginous, osseous, rhabdomyosarcomatous, or liposarcomatous differentiation. So this is just to show you the heterogeneity of metaplastic carcinomas. Here you can find the lesion has very spindly cells, bland looking. This is another metaplastic carcinoma with chondrosarcomatous areas. Here you can see a lot of matrix. So to definitively diagnose a metaplastic carcinoma, you need to identify epithelial differentiation. So you have to look very carefully. You have to sample the tumor extensively, and you'll actually need a combination of immunohistochemical markers, the epithelial markers, because if you do just one or two, they might be negative. So you actually need to apply multiple epithelial markers. And if any of them turns positive, it's probably an indicator towards a metaplastic carcinoma over other mesenchymal spindle cell lesions. Now, if you look at the molecular subclassification, their immunoprofile is usually triple negative, and they are treated like stage-matched triple negative breast cancers. So this is just a very bland-looking spindle cell tumor, as you can see here. And on IHC studies, they turned out to be CK positive. So this was a low-grade fibromatosis-like metaplastic carcinoma of the breast. Now, the other important site-specific mimic is a Phyllodes tumor. Phyllodes tumors, as our previous speakers have already alluded to, they are fibroepithelial neoplasms with admixture of stromal and epithelial components, where the stromal component is the actual neoplastic clonal component and the epithelial component is non-neoplastic. So you could have benign, borderline, or malignant Phyllodes tumors based on their stromal characteristics. What often arises as a differential for your spindle mesenchymal lesions in the breast would be a borderline or a malignant Phyllodes tumor. So what are the stromal features that you would take into account? They are stromal cellularity, stromal atypia, stromal overgrowth over and above the epithelial component, the mitotic rate, the tumor borders, as well as presence of malignant heterologous stromal elements like, say, chondrosarcoma, rhabdomyosarcoma, and so on. So the cellularity, atypia, mitotic rate, they all increase from benign to borderline to malignant. The tumor borders often become more extensively infiltrated in a malignant Phyllodes tumor. And the epithelial component that we described, which coexists with the neoplastic stromal component, is sometimes very difficult to find in a malignant Phyllodes tumor, and you might have to do extensive sampling. So that is how malignant Phyllodes tumor pictures in the differential of a mesenchymal spindle cell tumor. Heterologous malignant stromal elements if present, you can directly call it a malignant Phyllodes tumor in the presence of benign epithelial component. Now, this is just a picture of a classical Phyllodes tumor. You can see the lobular pattern, and this was the leaf-like pattern which Madam had shown you earlier. So even on imaging, you can appreciate the cystic spaces with the leaf-like fronds. So this is a malignant Phyllodes tumor wherein you can find the overgrowth of stromal spindle cells with atypia. But then you are lucky if you could find a benign epithelial duct like this, which probably gives you a hint that this could be a malignant Phyllodes tumor over other mesenchymal neoplasms. Sometimes you get malignant heterologous elements like a chondrosarcoma inside a Phyllodes tumor, and that suffices to call it malignant. But mind you, you can get these even in metaplastic carcinomas and other primary mesenchymal tumors. This is rhabdomyosarcomatous differentiation. So just a few words about the management of Phyllodes tumors, NCCN guidelines. Benign Phyllodes tumors, they are resected with as negative margins as possible, and then you follow up the patient. For borderline and malignant Phyllodes tumors, again, it is wide excision of tumor. Axillary staging is not recommended. And if there are high-risk features like positive surgical margins, tumor size more than 5 centimeter, or high-grade pathological features, radiotherapy may be considered. And AJCC 8th edition as well as WHO recommends staging malignant Phyllodes tumors according to the guidelines for other soft tissue sarcomas of the extremity and trunk. So now we move on to the big heterogeneous group of mesenchymal tumors of the breast. They are very heterogeneous, but mind you, they are very rare. So I'll just superficially cover all these different lesions. We'll give you just the salient points. In the slides, I've also included some major important molecular alterations, but I'll not be discussing all those. We'll just give you a bird's eye view of all these lesions for want of time. So first, going to the big group of myofibroblastic or fibroblastic lesions. First, as I told you earlier, myofibroblastoma and PASH are relatively breast-specific lesions. So myofibroblastoma is a benign fibroblastic tumor, and it was originally described in the breast, hence the term mammary type myofibroblastoma. It usually presents as a superficial, circumscribed, painless mass and is often mistaken for a fibroadenoma clinically. Now, it was supposed to be quite common in males too. And on microscopy, you can find very bland looking spindle cells, sometimes minimal atypia. There could be intervening collagen. You don't find ductal components intervening. You can find adipocytes. So you have different variants like lipomatous, epithelioid, myxoid, collagenized, and so on. IHC markers, as I told you, are very important because of the significant morphologic overlap. So, and what you should understand is for all these lesions, it's not that you throw a big panel of IHC markers. You have to be judicious in your use of IHC markers. You have to study the morphology and apply markers accordingly. Otherwise, they may not help you. So these lesions are usually CD34 positive, Desmin positive, BCL2 positive, and even ER positive. And total excision would suffice to treat them. The next lesion, which is breast specific, is a pseudoangiomatous stromal hyperplasia. So this is a benign myofibroblastic proliferation in a very collagenous stroma. And as you can see here, the cellular proliferation appears to line these slit-like spaces. And that's why it's called pseudoangiomatous, because these spaces might resemble vessels. So this is actually considered to be an aberrant response to hormonal stimulation, and often it's an incidental finding adjacent to or as part of another breast lesion, like maybe a fibroepithelial lesion. But they may appear infiltrative at times. So IHC, they are pseudoangiomatous, so your typical endothelial markers are often negative, variably positive for smooth muscle actin, CD34. And unless it is specifically required, these do not need excision. Coming to the next benign tumor, nodular fasciitis, which you can encounter at other sites of the body too. These are painful, rapidly growing, and so often mimic malignancy. They usually involve the subcutis in younger patients. And on microscopy, you can find these loose vesicles of spindle-shaped cells without significant atypia. It is typically referred to as the tissue culture pattern. But the problem is these could be infiltrative with very brisk proliferative activity or mitotic activity with extravasated RBCs and lymphocytes. And because of their proliferative activity, the infiltrative nature, they can often mimic malignancy. So immunohistochemistry, they typically show the Stram-Track pattern for SMA. And in all these cases, as I told you, it's of utmost importance to exclude a metaplastic carcinoma. And so you need to run cytokeratin or epithelial markers on your slides to rule out any epithelial differentiation or a metaplastic carcinoma. So coming to the intermediate group under the fibroblastic, myofibroblastic lesions, the relatively common one is a desmoid fibromatosis. This is a locally aggressive fibroblastic, myofibroblastic tumor with a high tendency for local recurrence. These could be sporadic or associated with FAP, and they also clinically simulate carcinomas because of their infiltrative growth. So on microscopy, you can find these long sweeping fascicles of very bland looking spindle cells with tapered nuclei, and often there is entrapment of benign breast ducts. Mitotic activity is not much, so it's very low grade looking. Immunohistochemically, they are usually positive for smooth muscle actin, and a very useful marker would be beta catenin, which is positive in 80% cases. So as you can see here, bland, long fascicles of spindle cells. You can see some ducts here at the periphery and the infiltrative nature of the tumor, and beta catenin positive. Now, resection is definitely the treatment modality, but local recurrences in fibromatosis are quite difficult to predict. So radical resections as well as re-excisions of posterior margins can actually be avoided. You can actually follow them up and wait to decide on the further management. Another tumor in the intermediate category is your inflammatory myofibroblastic tumor. It's very rare. Here again, you have these spindle myofibroblasts with a lot of inflammation. They can also resemble breast carcinoma clinically and radiologically. So again, these tumors are positive for markers like smooth muscle actin. And a particularly helpful marker would be ALK, though it may not be possible in all. It may not be positive in all cases. Another myofibroblastic tumor of low malignant potential, which arises rarely in the skin of breast and axilla, is a dermatofibrosarcoma protuberans. It has a high risk of local recurrence. Morphologically, again, you have pretty bland looking uniform spindle cells with what is known as a striking storiform architecture. So we have a fascination for all these different terms for patterns. So here you have this typical storiform or a spoke wheel kind of pattern of arrangement of spindle cells. And you can see them infiltrating the fat in a very honeycombed fashion. Okay. And this is CD34 positivity in a DFSP. So I've come to the end of the discussion of all these major myofibroblastic lesions. In all these cases, you found that there is a lot of morphologic overlap with spindle cells showing minimal atypia. So what is most important here is to exclude a fibromatosis like metaplastic carcinoma, which is a low-grade spindle cell metaplastic carcinoma. So you have to hunt extensively for any conventional appearing carcinomatous areas as well as keratin immunoexpression. At the other end of the spectrum, you have just simple scar tissue, which can also mimic a spindle cell neoplasm. So other features like fat necrosis, inflammation, or a foreign body type giant cell reaction might give you a clue that this could be scar tissue. And you need to resort to all these ancillary tests. So this gives us an idea for the importance of the ancillary tests. You have to have a very wide differential diagnosis. You have to sample the resection specimens extensively and use targeted immunohistochemistry panels as well as select the molecular assays judiciously. Then you have to integrate the information with clinical and imaging findings to arrive at the final diagnosis. Now, just to show you one case of ours, this was a 40-year-old male who presented with a swelling on the right side of his chest. It was rapidly increasing in size over the previous 6 months. At presentation, it was a huge 12-centimeter mass involving entire right breast. And on imaging, there was loss of fat plane with chest wall muscles. On TrueCut biopsy, it turned out to be a relatively bland spindle cell neoplasm like this, with SMA and beta-catenin positivity. It was negative for all epithelial markers, and so we gave a diagnosis of a possible desmoid fibromatosis. So mind you, this is a desmoid fibromatosis, but you have a very close lookalike, that is fibromatosis like metaplastic carcinoma, which you always need to exclude before diagnosing a pure mesenchymal tumor. Coming to the vascular tumors, hemangiomas, they're the most common benign lesions. They may present as a mass, and the commonest subtype is a perilobular adjacent to a lobule. They are circumscribed with vessels lined by very uniform looking endothelial cells. Angiomatosis is again a benign, rare vascular proliferation, but it typically involves a big area of the breast parenchyma and overlying skin. So it can mimic an angiosarcoma. Angiosarcoma is the most common malignant primary mesenchymal tumor of the breast. So this is a very important point. It's the most common malignant primary mesenchymal tumor. It could be divided into primary angiosarcomas, which arise de novo, or post-radiation secondary angiosarcomas. They present as poorly defined masses, and irrespective of their morphology, they behave aggressively, and so they're considered high grade. So treatment is by total mastectomy with or without radiation. Here you can find the infiltrative growth pattern. You can find these vascular channels lined by atypical looking endothelial cells. And these are the common endothelial markers: ERG, CD31, CD34, D240. Now, in this context, I'd also like to just allude to the atypical post-radiation vascular proliferations, which were originally described in 1994 by Feinberg and Rosen. They're cutaneous vascular lesions that occur in areas which were previously subjected to radiation therapy. So they can be solitary or multiple papules or plaques in the skin of the breast, and the typical time period after which they are seen post-radiation therapy is around 3 to 6 years. They generally follow a very benign course. So here you can see a collection of dilated, thin-walled vascular channels, a very circumscribed area. But what is most dreaded is a post-radiation or a radiation-associated angiosarcoma, which occurs in around 0.1% of patients with breast carcinoma managed with local surgery and radiation. So the median interval is around 6 years, and it arises in the skin of the breast, rarely in the parenchyma. So microscopically, they're not very different from the conventional angiosarcomas. So this was one of our cases of a 68-year-old female who had a history of MRM and radiation for CA right breast 10 years prior. And she had chronic right upper limb lymphedema. Now she presented with red-black nodules on her upper arm, and a biopsy confirmed that it was angiosarcoma. So this was a case of a Stewart-Reeves syndrome, angiosarcoma arising in chronic lymphedema, for which her right shoulder disarticulation was done. So this was the biopsy, very cellular, pleomorphic looking cells and earth positivity. Briefly about peripheral nerve sheath tumors, neurofibromas, schwannomas, they're benign and usually do not require surgical excision. But again, mind you, you have to rule out metaplastic carcinomas and myofibroblastic tumors. Granular cell tumor, again, mimics malignancy because of its infiltrative nature. They're derived from Schwann cells. This is a granular cell tumor infiltrator. This is a neurofibroma, bland spindle cells loosely scattered. This is a typical schwannoma with the palisading Verroque bodies. And this is S100 positivity in a schwannoma. But when you have a peripheral nerve sheath tumor with marked hypercellularity, frank atypia, or really worrisome features, you have to think of evolution into a malignant peripheral nerve sheath tumor, the malignant counterpart, which is relatively rare in breast. They present as infiltrative masses. They can have heterologous sarcomatous elements. So there's a lot of overlap with other spindle cell mimics, that is your metaplastic carcinoma and malignant phyllodes tumors. Adipocytic tumors, I'm just rushing through them. These are benign neoplasms, lipomas, where there is no nuclear atypia. You can have angiolipomas with small vessels and fibrin thrombi. But if you have nuclear atypia, you have to consider atypical lipomatous tumor or a well-differentiated liposarcoma. So when they're superficial tumors and amenable to complete resection, you can use the terminology atypical lipomatous tumor. If it is deeper, difficult to resect, you end up calling it a well-differentiated liposarcoma. Sometimes they have a non-lipogenic high-grade sarcoma adjacent to them, then it becomes a dedifferentiated liposarcoma. MDM2 amplification is the typical molecular alteration. Now, more commoner than a primary would be a liposarcomatous differentiation in a phyllodes tumor, but that alone doesn't suffice to call it a malignant phyllodes tumor. So this is an atypical lipomatous tumor with nuclear atypia in the adipocytes. This is dedifferentiation. Smooth muscle tumors, again, very rare. Leiomyoma can be there in the nipple or in the skin. They are typically SMA, desmin, caldesmon, positive on IHC, very bland looking spindle cells. And the malignant counterpart is a leiomyosarcoma. So if you just consider the list of spindle cells, you have tumors with bland spindle cells, you have tumors with atypical spindle cells, but there is a lot of overlap. You can have malignant tumors with bland spindle cells like a metaplastic carcinoma, and you can have just granulation tissue or a biopsy site reaction with atypical spindle cells. So this again tells you that it's very important to have a wide differential diagnosis, adequate sampling, targeted ancillary techniques with integration of all clinical and imaging findings. So just to show you the morphologic overlap again, and a reminder never ever to forget the site-specific mimics. This was a metaplastic carcinoma where we managed to find some epithelial differentiation. This was a malignant phyllodes tumor, which looks pretty much the same with spindle cells, but somewhere down the line on extensive sampling, we got these benign epithelial elements. So management, there is no standardized guidelines, but all agree that surgical resection with negative margins is mandatory. Sentinel lymph node biopsy not routinely performed. Grading and staging is similar to sarcomas at other sites. And you might have to do metastatic workup too. Neoadjuvant chemotherapy may be considered for inoperable cases. So these are the lesions that I've tried to cover in a nutshell. I think I've exceeded the time by 2 or 3 minutes. But just to conclude, malignant mesenchymal tumors, they are extremely rare, but they're very challenging. And our current understanding is also limited based on mostly case reports and small retrospective studies. Guidelines are also rather heterogeneous, but all would agree that surgery with clear margins is the cornerstone. These are some of the nice articles and our WHO classification of tumors. This is our team at Amrita Pathology. Thank you for patient listening.
Thank you, Dr. Jyotsna. So maybe we can take a question or two. Actually, there are no questions in the QA box. Ma'am, do you want to ask something?
Yes, I had one. Dr. Safalta?
Hi. I was
Hi. Do you?
just looking at the question answers and there were no question answers. So the
Okay.
lectures were so comprehensive, and the toughest part of the oncology link is pathology.
Okay.
Maybe your answers, questions will come now. Safalta, give it a minute.
So I had one question for ma'am, Dr. Jyotsna, all of you. When we label it as metaplastic carcinoma, we have also had situations where it was initially labeled as metaplastic carcinoma and later on it turned out as a malignant phyllodes tumor. I had one case similar. So Dr. Jyotsna mentioned a wide array of immunohistochemical chemistry markers. So is it mandatory to do all these markers on core needle biopsy before you label it as metaplastic carcinoma?
Yeah, I think I'll just give you my viewpoint on this. So, the differential diagnosis for a spindle cell neoplasm in the breast, first, second, third, is a metaplastic carcinoma. So,
Yeah.
before you give a rarer diagnosis of maybe a malignant phyllodes tumor without seeing an outright benign epithelial component, or you diagnose some other rarer spindle cell neoplasm without seeing definitive features, it's mandatory that you apply a battery of epithelial IHC markers and rule out metaplastic carcinoma as far as possible. Now, if you're going for a primary resection, then you have the luxury of getting more tissue. In that case, you have to probably sample it extensively, if not entirely, to look for any sites of epithelial differentiation.
Usually, because these patients, because they are triple negative, they undergo neoadjuvant systemic treatment, then it becomes, a bit challenging for us. And especially
Can I
if
say
so.
something?
Yes, ma'am.
So we have an algorithm we follow in Tata Hospital because, as you said, on a core biopsy spindle cell, and you say malignant, if you don't qualify as malignant phyllodes or this thing. So number one, we have a radiology review. So we look at the age of the patient. Very, very important, because in younger patients, less than 40 years of age, I never diagnose a metaplastic carcinoma. And it's very uncommon unless there is a family history of BRCA. So BRCA positive cancers, they often have metaplastic presentations, but otherwise it's rarer. So I'm not saying 100%, but it is rarer. Okay. So we look at age. So anything less than 40, we say that this is the differential. So remember, we rely very highly on cytokeratins, that if you have strong diffuse cytokeratins, but I've seen phyllodes tumors with very strong cytokeratins. So I use a dollop of salts before I use cytokeratin. I always look at, so in radiology circumscription, the age of the patient, and whether there are any fluid intensities at the periphery, because 1 or 2 cases we've got like that the radiologist said that clinically this looks like a fibroadenoma. Then you know that yes, metaplastic is out, and then you ask for see, it is a real serious doubt. The problem is we have 6-7 centimeter phyllodes and a 6-7 centimeter metaplastic carcinoma. I just thought I will. So 6-7 centimeter and the chemotherapy becomes a very integral part. So in such cases, you have to discuss with the clinicians, make sure that you don't or repeat a biopsy. So we've had these cases. So I have an algorithm. I show that first is, if it's very critical to give chemotherapy, then repeat a biopsy from one of those peripheral areas, because most radiologists think that periphery is cystic, so they don't go in those areas. So go at the periphery areas when you have a diagnosis of a pure spindle cell sarcoma or something like that. And then it is. And one case, I did NGS because this was a VIP patient. And what happened was, it came with very weird sarcoma markers positive, very weird. like it came with MDM2 and all. And my colleagues, oh, this is a soft tissue carcinoma, we have to give, chemotherapy. So I said, no, I still feel it's a phyllodes tumor. It was a, sometimes the borderline ages 42, 43 and all. So we did a NGS and it came TET2 med 12 positives, telling that it's a phyllodes tumor. So then, it came a little while back, and because there was this dilemma, patient nevertheless got operated. But for me, that was actually, I always hunt for that case, but I never find it, that was important. That we discussed so much amongst our colleagues. Two of us favored phyllodes, two of us favored metaplastic. It was an A1, A3 positive, ARG. I tell you, these markers, sometimes you were saying a wide repertoire, sometimes it's just the discussion. It's adding 15, 20 markers do not help, especially in this situation. And I'm not saying do NG. Yes, but if it is life-saving, then please do it, because the mutations in phyllodes are unique. So in that case, everybody is surprised that, oh, you got, and I was very thrilled because, see, I told you so, but not like that. But this algorithm works for us in most cases, and I would advocate that.
Ma'am,
Thank you, ma'am.
NGS, I believe NGS, most of the clinicians won't wait. I mean, still not impacting.
No, Kavita, in this case, it was a 10 centimeter mass, and whether it's a sarcoma,
Agree.
differential includes
Agree.
sarcoma,
I think I'm
metaplastic
totally
carcinoma,
agree.
and phyllodes.
Mhm.
And it's not possible. The thing is, it is amounting to a mastectomy, and if it was there were critical questions there. So
Yes.
they didn't want to operate
Right.
without giving chemotherapy if it's a metaplastic, or even for that matter, a sarcoma. So that is the reason we did all this thing. But anyway, you're very right. Your surgeon didn't wait. They operated before NGS, because NGS takes
Yeah.
10 days. You're very right. I'm just telling you.
But then, ma'am, but then this definitely primes us, know that yes, we have an option, and definitely we can at least convey to them
Correct. So
later
there
on
is a
probably.
series of, definitely it helps. It may not help you within fibroepithelial, but there's a recent paper in AJSP also which says the same thing, that all these sarcomatous lesions, they did, of course, US is privileged, everything gets for AJS, but I'm saying that in a life and death situation, we might try that out. And we did it only once. No, I'm guilty as charged. I will not
Okay.
recommend in every case, but wherever it
Yeah,
makes sense.
so agree, ma'am, agree. Because CK does come positive in malignant phyllodes. I've also seen one case.
Yeah, and
In
probably
fact, ma'am, focal P63 also at times comes positive.
yes,
So
P63 does come, yeah.
P63 also, and then those are those
So you
diagnostics.
should never believe in P63 without cytokeratins, because
Yeah.
P63 is a wide, it comes in everything. It comes in
Yeah.
lymphoma, it comes in everything. So moral of the story is that I think experiences and mistakes will teach you faster than anything else.
Yeah,
Absolutely.
so and though the topic was mesenchymal tumors, I think what would invite more discussion would be these mimics, metaplastic carcinoma and a malignant
Correct.
phyllodes tumor.
I think
Yeah.
for us clinicians, that is where we get confused, and especially if the patient doesn't respond to conventional chemotherapy, which usually triple negative are expected to do. Dr. Goel seems to have some question. Sir, do you? You're muted. You're muted, sir.
Yeah, it's been wonderful talks and really illuminating. Matlab, rather than a question, I am maybe more of a loud thinking. There is so much of an element of surprise findings on molecular testing with a similar pathology. Should we be thinking about a routine sort of molecular testing?
No, madam. No, sir. Sorry. No, sir. No, definitely no, sir. Breast pathology is very simple. I'm just telling you anecdotal instance. I'm not saying that molecular is important. I am looking at molecular in phyllodes tumor. So that's one of the reasons that, so some of us are crazy, and that's why I'm very much passionate about phyllodes tumor. So I do all these things. It is not the standard of practice. And technically breast pathology, what we really need molecular is in those flat epithelial atypias, the low grade DCIs, we need molecular in that. And I've been asking many people, and there is so much heterogeneity there. There, I think we need molecular, because those lesions, it is a patient's
to be followed.
anxiety who you tell her that it is DCIs or not DCIs. And so clinician is worried. We've had so many cases in this years. I always tell my colleagues, we have to do something about this, because the anxiety the patient lives with, that is, we tend to, in India, we are privileged that we have a very philosophical outlook, that we tell the patient that, see, this is the thing, we don't know what it is, so we can follow you up, and we know that it doesn't. But in all these developed countries, they would straight away go for, excision, counseling, and a whole lot of things. So it's a traumatic diagnosis more than the invasive, because invasive, you have a plan of action. These
Correct.
intraepithelial lesions, they are, especially in younger women, are a nightmare.
So I had one question regarding PLASH, because usually we see young women with large areas of firm to hard masses, and usually we say that excision is not required. So I was a bit curious about what happens to those lesions. What is the natural history of these lesions?
So
Because
you
women,
opened a Pandora's box. I can give
I
it
had,
on this. So
ma'am, we had
anyway,
one case.
so the
I sorry.
problem with the so as I said, you're all practicing, breast purely. So these are like
Yes.
so PASH is not a distinct entity. Number one, it is
yeah,
just a stromal response to a variety of. My suspicion is androgens. So we see this especially in pubertal females where
yeah,
there is a androgen excess over the normal things. I have been trying to prove this, but I don't have. It's not a common thing, and clinicians say, "Why you want to do blood tests in a PASH? Just leave it alone." So
right.
the moral of the story is, number one is that I think these are hormonal changes. They regress, they produce dense collagen-like sclerosis, and they will produce a breast density which mimics carcinoma. So
Yeah,
all these are the clinical mimickers, but it does not have any kind of connotation about anything except that this is definitely an hormonal event. And what happens is when you see PASH, people tend to call it fibroadenoma, something, 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 but PASH is just a stromal change. It can occur in the fibroadenoma, it can occur without any fibroadenoma, it can occur anywhere. So, a collagen is collagen, whether it's what happened was it piqued us in the beginning, so that interest has remained. So people find our radiologist had a session, and after when we talk now, they're not excited about PASH anymore.
I'm just resonating with you. Actually, we had a case of a prepubertal girl. She was diabetic also. I diagnosed, like, I gave PASH as a diagnosis, but uska to breast was like enlarging and enlarging. Same. I read about it because the clinician was also worried. And again, same, hormonal driven, definitely. And I think I read somewhere, as you're saying, yes, anti-androgens are like maybe.
So I think I am convincing our people. So I'll tell you one very sad story that it was, so like you said, enlarging. Somebody gave imatinib and the child died because of the imatinib. And I curse
Oh,
myself that I could have stopped this, because see, the problem is that the patient is very, very tender, and to have these massive breasts is not a good thing, and
right.
it's emotional trauma. So parents do whatever experiments we say. There is some paper on AIMS from hormonal, but I think more than those progestational drugs, I think androgens should work. We've not yet tried in anybody. I'm itching to try because I don't find a clinician who is supportive to try. So I think we should give it a try, because it's just a drug and you can stop it anytime. And androgens will not cause so much harm as all the other things do.
And like you said, ma'am, I think many a times you see it coexisting within maybe fibroadenomas, within phyllodes. And nodular PASH, I mean, I encounter very rarely actually.
So I think we had an excellent discussion on varied aspects of breast pathology. Dr. Prekshi?
Yes, ma'am. So
Yeah.
now I request Goel sir to please give vote of thanks.
I'm sorry, I have to leave for something. Is that
Yeah,
okay? Thank you so much,
sure,
everybody.
ma'am. I am really grateful, and we really enjoy your talks so much.
Thank you so much, sir.
Absolutely.
Thank you,
My
Vaishali.
pleasure.
Bye.
Thank
Bye.
you. Thank you, ma'am. Sure.
So I would like to first and foremost say thanks to the delegates who join, and the response we have always had has been really increasing our enthusiasm, and that is why we have been able to continue this for 5 years, and like hope to continue as long as possible. Other than that, definitely all the faculty deserves a great round of applause and our sincere, heartfelt thanks. It's always a lot of hard work preparing a good presentation, and these have been very illuminating. So thank you to all, and definitely our team of Dr. Prekshi, Dr. Vaishali, Dr. Safalta, and all, they are really sort of doing the hard work now. And Mighty Duo again, they are managing the show very well. Thank you. And we'll be back soon with the next episode. We'll share the details soon. Thank
Thank
you.
you, and